All right. Thank you very much, everybody. So I'm Mike DeFilippo. I'm one of the board members for SAEM Rams, and I really appreciate you all taking your time, both the panelists and the audience members, for coming tonight. The focus on this talk is just going to be on effective skills in the emergency department to teach as a resident. This is also focused for rising medical students who are going to be residents very shortly, how to teach in the ED to various different learners. As if EDs weren't chaotic enough, many of them are staffed kind of like this with a revolving door of medical learners, from medical students to emergency medicine residents, off-service rotators, other paraprofessionals. So the ED doc actually has a very critical responsibility in the ED in addition to emergency management, and that is to teach. The central tenet of what we do has historically been based off Hippocrates or the Socratic method, always to teach forward. However, some of that has been changing with recent literature and updates in education learning theories. To some of us, it comes very intuitively. To others, it's a little bit of a struggle. So today, we can all use some teaching on how to teach. So I've collected some of my colleagues and mentors here to teach with you. So just going to have them introduce themselves. I'll go in order, and starting with you, Dr. Garg.
Thank you, Mike. Really appreciate the opportunity to be here. I am the residency program director at New York Presbyterian, Cornell, Columbia. Just thrilled to be here and happy to be a part of this thing. Thank you, Mike, for inviting me.
And Dr. Kristen Leck.
Hi, everyone. Welcome. I'm one of the APDs at Cornell in emergency medicine as well. And I'm also the director of the Medical Education Fellowship.
And Dr. Adam Blumenberg.
Thanks, Mike. So my name's Adam. I'm a core faculty at Columbia University. I'm also a medical toxicologist, emergency physician, and simulation educator.
Awesome. Very excited and happy to have you all here today. So before we even start the lecture, I always think it's good to get at least some background, just sort of like your philosophies and, why do you teach and what sort of drew you into a physician role that has teaching involved to it, as opposed to just going out to the community to a job you clock in, clock out, and all you have to worry about is the job.
Chris, or Adam, you want to take that one first? You want me to go first?
Yeah, I can go. I mean, I think I think part of it is, I think, like a very selfish reason, because, if you're kind of able to teach it also like a topic, you're also keeping your skill set very sharp by being able to teach a topic well. And, it's really, I think, great to also just see like people's growth over time, especially like, when particularly part of like a residency group is like really seeing like people's growth, like over 3 years, 4 years, whatever it might be. And they also, I think, in a way, like, teach us a lot in terms of like keeping on top of like, the most up-to-date literature, the most up-to-date topics. And I think you also, again, surrounding yourself with learners and, with others like in the academic space, also like really pick up on like tips and tricks yourself, like from other groups as well, that are really helpful, like for, again, like both teaching and learning for us.
I like Christy's answer. My significant other always just said that I got into this so that I could hang out with people. And then people would be forced to laugh at my jokes. I would say that I love the question, Mike. I think for me, I actually look at it in a few different ways. I look at it holistically. One, I really think that if you understand it, kind of like Christy mentioned, at the level of an educator, then wouldn't you be giving the best care for your patients? Two, I also think about all the amazing educators and teachers that have gifted me their presence and the ability to learn over the course of my career. There's no way to pay them all back. So I guess I try to pay forward that skill set. Three, I also think there's the possibility that if you can teach the next generation of doctors for tomorrow, then you will absolutely improve your footprint in terms of the amount of patients that you could potentially take care of. And then finally, just, I got to tell you that just seeing the spark, just seeing, you explain something to a learner, they get it. It's the best thing in the world. And so, we get to take care of amazing patients in our communities. And then it's just gravy getting to work with like these amazing learners. So being there and watching them develop and getting a front seat to that, nothing better.
And I completely agree with and kind of echo everything that's been said. And Manish, I love that you kind of mentioned the spark, because I completely hear what you're saying. That you're having a conversation with someone. It's there's a two-way back and forth about a topic, and you both get into it, and the learner's excited and you're excited, and you've taught them something new, and you're probably learning yourself, or at least I certainly am. And then I also completely agree with Christy, what you said about kind of it keeps you sharp. We have these journal clubs, we talk about what's the cutting edge literature, what's new out there, and that's a very exciting part of it too. And then also, I think you both mentioned this, and I wholeheartedly agree with it, is that longitudinal relationship. I love being an EM clinician. For the most part, we see our patients once and probably never again. But to work with a learner, to teach them something, and then a few months later, they come up to you and say, "Hey, that thing you taught me, I used it in patient care and it helped." It's a pretty amazing feeling.
Thank you all. So it sounds like, definitely some two-way learning, both for the learner itself and for you guys from the people you are teaching, as well as, some personal satisfaction out of it. So now to get to like the nitty gritty of it, what is your general approach to teaching while on shift? In the emergency medicine FOAMed world, there's a lot of blog posts out there and a lot of advice on how to approach teaching, especially on a busy shift if you don't have a lot of downtime. One popular model that's thrown out a lot is the 1-minute preceptor model. One model that's routinely used all throughout medical school, and I think in most specialties, even outside of medicine, is sort of the Socratic method of questioning to really probe your learner. Is there any particular teaching method you use, you like to use? Do you use a mix of them, or is there something in particular that's not mentioned that you prefer to use?
I think for me, like, I think this is like emergency medicine in general. Like, I think we've like luckily gone away from like the whole model of like pimping, for like lack of a better word, like where you do things like in a way, in front of like the patient, in front of like, others like that may be with the patient. I really like, and I know we have like a couple of residents on the phone, is really like as best as I can, really like going to the bedside and like watching kind of things unfold in terms of how the learner like approaches the patient, gets the history, like does exam, like hones in on specific things related to the patient's presentation. And I feel like the benefit of that is twofold, is like you're getting essentially like that SDOT type view where you're like seeing like how things are asked, like things that may be missed, or again, like really well done ways of like people communicating with patients and like eliciting like focus histories and doing exams. It also saves time for me, because I think for all of us, like really like the meat of, when we're kind of like discussing a case and then like teaching, is really like assessment and management. And so I'm like, like we don't need to talk about like 2 days, it's 3 days of chest pain and da, da, da. But like let's just kind of talk through like what you're thinking about like the chest pain now that we've like kind of collected this data together. And like let's sit down, like let's look at the EKG, let's talk about like the things that we're ordering and why. And I think that it's very helpful then for me to give feedback, because I'm like giving it off of like the realest information possible. It's not something that's like self-reported. It's like what I'm observing. And I think, what I'll also do then is, kind of like fill into like if I'm noticing like, hey, maybe they missed this part of the history, or I would kind of ask this or do this, I can fill it in. And that also I think kind of serves as like a learning point as well. Like, okay, when, this, in this situation, like perhaps I should have asked like this about social history or something else. So I think it helps with efficiency with kind of bedside teaching, but then it also helps us to give like very relevant, like specific feedback to the learners when I approach kind of my shift that way with a student or with a resident.
Thank you, Dr. Leck. I just have a clarifying question. So, there's two types of observation, at least that I was in reading the literature that I've seen. It's active, and then what's called sampling observation. So sounds like your approach is a little more active in the sense that you go bedside with the resident or the learner, as opposed to maybe standing behind the curtain and, listening in for parts of the exam or
Mhm.
during a procedure. Is that more so the approach you stylistically like to use?
Yeah, and it depends. I mean, it obviously like, depends like when you're thinking about like workplace learning and thinking about like the context. So there are cases where there are just like constraints, and so I'm like not able to do that every single time. And in certain situations, I think with certain learners, like, right, you can like feel it out if it's perhaps like a newer learner, a more junior learner, or perhaps like an off service rotator. Like, I know it's going to take them longer to kind of get to the point where I need them to get to. And so like I'll like go in like a little bit later when I know they're kind of hitting on like the relevant points, or perhaps like when they're doing their exam, to kind of like save time but still be able to give them direct feedback about the things that they're doing. So I think, in terms of efficiency, yes, it's not like a realistic expectation to kind of be there all the time. So there may be times where you hang back, or in other kind of situations that you think it may be helpful for them to like truly, truly take the reins. And you kind of, like you said, like listen behind the curtain or in the background.
Got it. Thank you. Go next to Dr. Bloomberg, please.
Sure, thanks. I was trying to think about this question because I kind of had a heads up that this is probably a likely question, and for me, I think if I have to distill it, it comes down to care, empathy, and content. And let me tell you a little bit about what I mean by that. So care has part can be a little bit of like a touchy-feely, we all get along part, but it's also just I want to do a good job at this. This is important. It's important that my learner learns, and I care about doing a good job. It means something to me, and to put out educational content and to make this person a better doctor, a better student, a better version of themselves matters. What ties into that is keeping in mind that everyone is an adult learner. So one of the, I think, positive things about the direction medical education is going is we're abandoning a lot of the kind of attempt to humiliate the I know everything and you know nothing kind of attitudes, and going more for really adult learners. And I'm very aware of that during a shift. I am the attending during a shift, but I'm aware that the moment the shift ends, we're just two human beings and that hierarchy completely collapses. This person in front of me, who I've been tasked to teach, they're more junior in training, but they may be my boss one day. And I take that very seriously. This is a person who trusts me with their education and training, and I care that they learn. So kind of coming in with that attitude, I find very helpful. It guides a lot of what I do, even on an unconscious level. Empathy, and I mean that, so the next one being empathy, kind of to me comes down to memory. Again, we have this kind of training on rails. At some point, we were all medical students. At some point, we're all first year medical students, then second, then third, then fourth. And then at some point, we were interns, then PGY 2s, 3s, and if you're in a 4-year program, a 4. At some point, we were an early attending. So I try to remember, what did I struggle with during those parts of my training? What did I find challenging? What were those epiphany moments for me? Because you bet I did not get born knowing any of this. It's a process for all of us. So kind of remembering a little bit about what were those signposts at each different stage of my training helps me empathize with the learner in front of me and helps me guess, what are they working on right now? What can I teach them? And that helps me just with my teaching style. Am I talking about evidence-based management, or am I doing the review of the stuff that you throw at a patient with hyperkalemia? It's different. How do you work with a PGY4 who's about to be independently practicing versus a first year who really wants to do a good job but is still struggling with the basics? So just kind of harkening back to my own experiences and remembering that, I find also helpful. And the last one is content. We have to actually teach something, medical knowledge, or other things like that. And I think content breaks down into 3 major categories. One is medical knowledge. What are the facts? What is the dose of calcium gluconate that you want to use to treat hyperkalemia? That's a piece of medical knowledge. What is the dose of epinephrine in this circumstance? That's medical knowledge. But the other ones are skills, right? So how do you effectively place a central line? How do you place an IV? How do you manage laboratory tests? These are skills. They're not all hands-on. Some of them are, how do you place an order? That's a new skill for an early intern, and it's potentially a tough one. I mean, I'm sure everyone here has misplaced an order, and I know I still do a couple of times a year. That's a skill. And then the last one is attitudes, and that's a challenging one because that also takes a lot of kind of interpersonal skill and care. I find myself included, hospitals are tough places, right? A lot of us go through a period of cynicism at some point during our training, or burnout or something like that. And so identifying negative attitudes on the side of a learner, it's not like this person sucks or they're bad or, they might just be going through a hard time. So if you identify that, a wonderful thing to do is to reach out and say, hey, are you okay? And to try to figure out some way to, this is going to sound a little cheesy, but to reignite the magic. Let's get something that engages you and talk about something that is fun and kind of at least try to go in that direction.
Reignite the magic. I like it.
The
Dr.
cure for
Carr.
burnout.
Yeah. Hot off the press. Yeah.
So I love all these points that both Christy and Adam brought up. I mean, I guess for me, I don't have like a set approach, Mike, when I'm trying to figure out exactly what or how I'm going to teach. And the reason why, I mean, I think actually you think about it like a death scenario, right? There are times where you might have a prescriptive way that's your ideal way that you would want to share with the family that their loved one passed away. Sometimes they're like a patient's family is like right up on you, and you've got to be able to tell them that in that moment. Sometimes you've got a chance to like lay it out the way you would want. So you have to have some sort of agility when it comes to figuring out, and those circumstances in how to teach might be on how busy the ED, right? Like it's always chronically busy, right? But is it busy enough for me to unwrap this thing for this learner in this moment? Is it such an important point that I need to do a deep dive in that moment? Or is this kind of like something because I want to make sure that I'm teaching something on every case? So when I was putting together a curriculum for how to do the like a resident as teacher curriculum, so how do you teach the teacher? One of the things that I really thought about was what's our best way to do information translation? I mean, essentially, it comes down to that movie Inception. Like, how do you put an idea in somebody's mind, right? And so I found that there's a few different ways that I could do this. And the first thing that I do is I think about human behavior, and people will best learn therapeutically if they feel that they're in a safe space and that they feel that their teachers are really rooting for them. So one of the things that I try to make sure that I do is just kind of give comments to throw in like, hey, awesome to work with you today. Like excited for, what's going to happen. Like, just to tell them like how much I appreciate that I get to share this time with them. And I think that just kind of like melts any sort of anxiety. So every once in a while I get the, oh my God, you're the program director. I was nervous today, especially from an intern, but that melts away after you kind of, build them up a little bit and just kind of tell them that, no, this is, I mean, I learn stuff every day too, right? So if you can get that connection, then you will be able to better have that teachable moment. After that, over the course of time, kind of like some of the things that Adam was talking about, like I have pillars in my mind. Like a lot of the hallmark of emergency medicine to me on a day-to-day basis is accuracy, efficiency, patient satisfaction, documentation, and leadership. Like those are 5 pillars that I'm always cycling in between to see if I can help somebody specifically with feedback. I also have like my 3-headed monster of medical knowledge, technical procedural tips, and art of medicine. So that 3-headed monster is something I cycle between two when I'm trying to teach somebody a particular thing. So in my head, Mike, you and I might be working together, and you bring up something and I'd be like, sweet, let me talk to you about a medical knowledge thing, or hey, here's the art of medicine. Here's how I talk to the patient when I'm approaching them for this thing. And so that way I can kind of keep myself cycling through stuff and not always saying the same thing as we go through. And then, after that, I think the other thing is to make it a priority and to make it a commitment. So, through working with me, Mike, that like when we first start off the day, I ask, what do you want to learn today? And, what do you want to work on? And if you tell me, I don't know right now, I'm going to get back to you, then I'll say, hey, you've got think about it. I'm going to come back to you in an hour. And I actually put a little thing in my phone to make sure that I come back to you in an hour. Otherwise, half the day will be gone. I try at some point, not just to be at the end of the day, but if I can in the middle of the day, do a little feedback thing. I think it's more powerful because the learners really appreciate when they can, actually put into practice some of your teaching pros on that shift. So you tell them everything at the end of the shift, it'll degrade before their next shift, or they didn't get a chance to show you what they did. So if you're a learner out there, I would absolutely say you can be an active part of this process with that commitment. You can actually approach your attending and say, hey, these are some of the things I'd really love to work on. I'd love if you could watch me, and maybe can we commit to some point in the middle of the shift having a conversation about things that are going well, things that aren't going well. The other thing that I love jumping on is that teachable moment. The big teachable moment is during resuscitations. For the emergency medicine person, pupils fully dilated, ready to learn. Everything's about to happen. And that's the moment where I think I can talk about, here's what you did with leadership. Here's how you did running the code. Here's how you, utilize the folks that were, around you. Closed loop communication. There's so many things in that moment, and just people absorb that as a sponge. So I also try to talk about it, and very important if you're going to go into this, that you frame it that way. Now I'm going to give you feedback. I know it sounds ridiculous to say that, but when they sample learners afterwards and say, hey, did your attending give you feedback? A lot of them will say, no, they didn't, but the attendings think that they did. And it's because they didn't frame it as feedback, And so then at the end of the shift, as you know, I'll usually ask the learner, what things went well for you today? What things do you think you could work on? And then, here are some of my observations on the particular shift. And I think all of those things help out a lot. If it's something more specific, like what Christy was talking about, am I following with them on a particular case? What's my best strategy there? I really love giving residents as much autonomy as I possibly can. Especially EM residents, it's all about autonomy and using us as expert consultants. But the key there is you need to be able to teach them, because any individual can only go so far. And that's where it's our really sacred responsibility to continue to give them all of the key pieces of deliberate practice that's going to help augment them for the future. So, it's important there. And I often find that folks who can actually be some of the more critical attendings, if done right, they will be the most beloved teachers.
Thank you all. That was actually some very impactful points, and I look forward to actually watching the YouTube on this afterwards to take some notes. So, going off some of the things you said, I think, one thing that was brought up in all three of your pieces essentially was, finding some way to engage the learner themselves in the teaching. So one thing I know I've struggled with as a senior resident, and, talking to some newer attendings as well as, some of my senior residents, is how do you get engagement from your learner, especially at different levels of learner? Sometimes for example, for me, one day I'm with, a second-year medical student that's shadowing, and then a fourth-year medical student that's on a sub-internship and an off-service rotator. So I find it sometimes difficult to sort of manage that from a teaching perspective. So I was just curious, your opinions and approaches to sort of approaching different levels of learners in the emergency department. Do you probe them to see what they want to get out of the shift? Do you have a structured way of doing it for everybody? We can start with you, Dr. Blumenberg.
Sure. And it does vary a bit. In my mind, a student versus a resident. Just kind of one of the big differences is that, kind of like Manish said, residents are there taking care of patients and being as autonomous as possible. And I'm available to kind of, when there needs to be a minor course correction, or to kind of expand on something, or to go into evidence-based medicine, or to dive more deeply. And with students, it can vary quite a bit too. Certainly depends on the individual. One thing I found is a general kind of approach that helps is earlier in medical training, um, they tend to be really amazed with connections between what they've learned in physiology and pathophysiology and the clinical tie-ins. So they're still kind of right there in anatomy class. They're still right there in learning about biochemistry and hating the Krebs cycle, and but still understanding about receptors and pharmacology, and feeling understandably a little bit overwhelmed. And to see how it actually ties into signs and symptoms or a change in vital signs, or how labs in a real patient demonstrate what they learned in a classroom, can be really amazing to them. So there's some things that can, I'm a toxicologist, so some of this can be from a tox standpoint, but a lot of it is stuff that we see almost every day in the emergency department. So, for example, DKA. That's a great one to talk about with an early med student, and how the acid base ties into the potassium, and the mechanism of ketoacidosis generation really can light up their eyes. Later in med school, it still can, absolutely. They tend to want a little bit more action. They tend to want to be hands-on in a resuscitation. They're eager to participate in CPR. They're eager to do a procedure. Those aren't guaranteed every shift. So something I have done in the past is to actually bring an open central line kit. One of the things that we see in the ED a lot is a piece of equipment will be opened and not used, or expired. And so if you get a central line kit, you have the triple lumen, you have the guide wire, you have the knife, the introducer, all that type of stuff, and you get some suction tubing, you tape it to the desk, and you go over Seldinger technique with them. And that's kind of a great hands-on experience. Another one would be suturing. So even if you don't have the opportunity to do these procedures on that case, because on a shift, because shift is kind of luck of the draw, um, you can bring a small amount of equipment with you and guarantee that they get something like that out of it.
Thanks for those tips, Dr. Bloomberg. Dr. Leck?
Yeah, so I agree with all of those really great points that that Adam made, and I think so for our junior learners, I think where I've kind of heard people wanting to work on what they're doing clinically is definitely like efficiency, and so making sure to kind of give feedback on that, and often like number of patients that they see on shift, and like getting documentation done. So I feel like kind of those things are like the things that juniors tend to focus on, or I think are like very granular, like very like specific feedback that like you can say like, okay, next time I work with you, like I'm gonna see like I'm gonna give you feedback on your documentation, or how efficiently you're putting your documentation in, or we'll talk about how you're like ramping up the number of people you're seeing per shift, or addressing bottlenecks in terms of working on shift. For the seniors, like I think kind of we all know they really want feedback specifically on like leadership skills, like interpersonal skills, like leading a code, and kind of managing like resuscitation scenarios. So I think that that's helpful, and Manish mentioned that earlier as well as perhaps like a little bit more of like evidence-based medicine. And now as a senior resident, how do I kind of teach my juniors on shift? In terms of like the students like off service rotators, I do think it's good to kind of like ask them essentially like what they want to get out of the rotation. Like obviously for the med students that are interested in EM, we're going to just expose them as much as they will want to like a variety of things. But for those like students that are going into other things, like this rotation may be the last time that they see like a certain population of patients. So maybe they want to like get OB exposure if they're gonna work with maybe like older patients, or patients only like of a specific gender, or maybe they really want to get good at procedures if perhaps like they're going into like a specialty that's like a surgical specialty, and practice suturing and other things as well. So I think that can be helpful to kind of speak with them, and some people are like, I just want to make it through this rotation, and they may not have specific goals, but I think there's a lot that they can still kind of get from the experience. I also want to say kind of in thinking about like our learners, it's also important, like when we talk about, we're talking about workplace learning, which is again, like where, the majority of the learning comes from for, when we're talking about residency and particularly like post-COVID times as well. Like there's just so much more weight on kind of what we're doing in the clinical space because in-person things still may be limited for ever, or at least for the foreseeable future. Besides kind of like acknowledging like the learner and kind of like their space, it's also important to kind of know about yourself, like the teacher, and then also like the context. And so realizing like, those some days are just kind of like the killer be killed days, and it would be nice to kind of have like these like very nuanced discussions, but I still think that in those situations where resources may be limited, everyone just trying to do their best, the volumes are really high, the acuity is really high. One thing that I think is applicable for everyone, no matter where kind of your learner is at, is role modeling. And so even though you may not, again, be explicitly saying like, this is how I'm going to, de-escalate this situation, like a patient or someone that's frustrated, you kind of modeling it again in front of them is something helpful. In addition, you can obviously talk about them about the case after it happens in terms of like techniques that you used, or just even like seeing how you as the attending manage, like, again, like a full board, you only have a few nurses, CT is down, whatever it is, is very helpful. And again, like your low resource setting, to really use like role modeling as a way to teach, all comers, all learners on shift.
Thank you, Dr. Luck. And finally, Dr. Garg.
So Mike, as I think about this question, I really think a lot about trying to stay grounded in knowing who my learners are. It's the same thing like when I'm giving a talk. I want to know who's going to be in the audience so I can find a best deliver it to that particular audience. This is the same thing, like in medicine and actually in life, you're always evaluated on whatever the next stage of your training is supposed to be, right? So we see that, right? Like the compliment that's written in everybody's letter as they go from being a student to ultimately being a resident is this person's performing at the level of an intern, right? Like that's like a magic phrase, right? Well, but similarly, when I'm seeing if it's a third year med student, I'm trying to think to myself, okay, in the SOAP note, they're essentially like going from information gatherer to synthesizer and plan maker. If it's the fourth year, I'm really trying to go like, I need you to hammer down on putting down the orders down, because that's what you're going to be doing next year. If it's the first year, I'm talking about, okay, let's make sure your accuracy is really good. You've got the right set of orders. You're thinking through a proper differential. If you hit as a second year, like they're thinking about efficiency next, right? The first years will be, right? Because they're seeing their rock star senior residents and they're like, I want to be like that, right? And then the second years, they're thinking about, all right, I'm going to be managing, I'm going to see all this volume now. So we start talking a little bit more about efficiency on that access. And then, they're thinking about critical care and the sickest patients, right? The third years at that point are thinking about what's it like to be running the entire bay and, as a senior resident, and depending if you're 3 or 4 years, in the final year, that pre-attending role, it's what is the clinician educator? And then also just to me, it's like, well, they're trying to think about what are all the things I'm going to encounter next year. So one thing I do ask on shift, and I try not to make it like a scary thing, is like, hey, what are you worried about? Like, for next year? And I think that they'll often share with me, and that's another way of me evaluating what somebody's self-perceived weaknesses are without actually asking them that. So whenever they tell me that, I mean, some of it might be structural, like, well, I'm worried about this new role change. Fine. But sometimes they'll actually give me some insight into the things that they're worried about, and I can do that. I also just make sure that, you're infusing enthusiasm like throughout the whole thing. So like, getting them excited about just medicine in general is, I think, what gives really good energy, to the whole system. And so like, whether you're a rotator, whether you're an emergency medicine resident, like, yes, getting people excited is how I get them engaged. And I can often find that I can get some good alignment once they can match my enthusiasm for, what's happening on shift. And then ultimately, like, we can supply each other energy through the shift. And I think that's what kind of helps me to better understand my learner where they are. And right, like everybody's at a different level too, right? So if somebody may not be, at a same space as one of their peers, that's fine. You as after you've been doing this for 20 years like I have, you can kind of identify those things pretty quickly in somebody. And um and I certainly know my two colleagues here who I marvel at when I work with them. They figured that stuff out a lot earlier than I did. So, I'll tell you that I think one strategy is just getting to know your people. So I go back to that as the key kind of hallmark to this question.
Thank you very much. Sorry, I just need to take a quick sip of tea. So the last question for our facilitated question part is, and I'm going to be starting with you, Dr. Leck. What are some common pitfalls you guys see in your experience with on-shift teaching? And, in your experience, how can those be avoided, or how can new clinicians, education clinicians, avoid those pitfalls?
That's a good question. So I definitely feel like, my kind of approach is always evolving with this. So I think, kind of going back to a point that we kind of spoke about earlier about just like creating like a safe space is just really like kind of setting that up. And you can even like verbalize it as well. And it sounds like kind of like, cheesy, but I think particularly when you're like having, again, like newer learners, like interns coming in, or new like off-service rotators, or like med students, like you say, we like believe everyone's like trying their best and like or doing their best, like, given like the resources that we have, to really like put people at ease, and then continue to kind of throughout the shift do things, and again in a way that's like fair to the learners, and make it safe for mistakes, to be made, and also like not again like embarrass them or kind of put them on the spot with patients. So again, like not really doing a lot of just kind of like too much discussion at the bedside, like in front of the patients. Like I always like cringe, like when people do that of, just again, like that pimping, or even procedurally, I'll also see that as well, where, you're kind of taking a learner that perhaps like, isn't totally comfortable with a procedure, or is doing a procedure for the first time. And it's like very clear to the patient and anyone else in the room that that's the case. And that doesn't help anyone be at ease in that situation. And so I say, like, when you're kind of doing like the lumbar puncture for the first time, the paracentesis, the central line, whatever it is we want to have like all of our discussions ahead of time. So sitting down and like walking, the learner through, like, these are kind of the steps for doing this, and they kind of repeat it back. And then, one thing, I'll do it procedure wise is, I'll tell the patient, I'm just gonna like walk you through the steps too, so you know what to expect, like each way. So like for lumbar puncture, I'll say, we're gonna lay on your side. Okay, great. And we're gonna have, we'll just remove your clothes, put a gown on. Now you're gonna feel paper on your back. You're gonna feel cold. We're cleaning, because that is also prompting our learner, in addition to like prompting the patient, and kind of also making them comfortable and know what to expect. And really just being, again, conscious of like my words, when I'm, again, doing things at the bedside with the learner, giving them feedback, and kind of directing them. I can also like talk about, I guess, like more like difficult like learning situations. I think the thing that people also, when I was thinking about this question, that people cringe at is like having to give like critical or constructive feedback to like a learner that may be struggling. And I think this is really the case, specifically for like interpersonal communication and professionalism issues. So like more probably for like senior residents, like junior faculty in general, is like, how do you kind of interrupt these situations and like and give people feedback? And so, there are a lot of obviously like techniques that you can use, but I think one of them, is I think obviously like removing the person from the situation when these happens, and like in in the situations where you do have to kind of give like critical constructive feedback about how something did not go as it should, is like using silence too, and space to allow the learner to like reflect on the situation. I think we want to like kind of like pounce and kind of give them like what we're thinking, but it's really helpful to give them like the space and the time to self-reflect, and they may kind of arrive at kind of the learning points that you want them to arrive at themselves, which I think is really helpful for their learning, to kind of again come to like the kind of the right conclusions and learning points themselves, with that. And then you can also provide some guidance as well and like some feedback about their performance.
Thank you very much, Dr. Leck. Dr. Blumenberg.
Sure, that's a I think a really important question in medical education. Kind of what are the pitfalls that I've seen or personally experienced? Um, and I I think I think a lot of people probably share this, which is essentially using harsh techniques, humiliation, shame, fear, intimidation, as learning techniques. It is being phased out, but we still see it sometimes. Personally, I've been taught this way a couple of times, and yes, the lesson sticks, but I'll remember it for the rest of my life. And while I was a trainee, I sure as hell will avoid that person. So you might be able to hammer one lesson in that way, but you're gonna kind of destroy that potential relationship going forward. Um, I'm personally not tempted to use those, but it is something that is still done sometimes. I think Christy brought up a really important point of how do you provide negative feedback in a way that kind of accomplishes the goal. You have to address the issue and teach the person, but also not not humiliate the person. And so what I do in those circumstances is I think very similar to what you do, Christy, which is one, I'm discreet. So I will make sure that nobody else hears the conversation. This will be a one-on-one conversation. I'll be making eye contact. The person will see my face and know that I'm not mad at them or yelling at them or anything like that. And kind of what Manish was talking about earlier, I'll be very direct and tell them my own experiences. Listen, I make mistakes too. Listen, I made this mistake. This is why I'm telling you about it, because I've done it before and I've learned about it. Or or if I haven't made that specific mistake, I'll find some other way to kind of demonstrate that I'm not perfect either. I've just been doing this for a few years longer. And I'm coming from a place of I just want to, make your skill set better. Um, and and I think that accomplishes two things. One is it addresses the issue, but it's also conversational. So there's a potential for back and forth. It's not just me talking at the person, at the learner. We can discuss what happened. And you could potentially even use some of these, formal debriefing techniques, which are often used in medical education and simulation. So just if you want to do a quick Google search, some of these are called plus delta or advocacy inquiry. Um, pearls, these are just kind of known didactic methods which you can use to kind of go over something that could have been improved. And if you're doing it in a one-on-one way and you care, it will be well received. It just will.
Thank you, Dr. Blumenberg. And finally, Dr. Clark.
Yeah, Mike, I love this, and I love the comments both Christy and Adam brought up. Yeah, Adam, I kind of go in with the adage of praise in public, perfect in private. I think that's a good way to do it. I think, Mike, one of the, like, over the years, I'm trying to think about some like subtle nuances that I've noticed, and one of them is when how we talk about processes in the emergency department. So we all spend a lot of time like thinking about operations. So like if you and I are working, I might say, hey, how would you like to run the board, or what would best help you with that. But we don't do that with education necessarily. And so what I learned, that where I was making a mistake, I started getting evals, and one, I think I think it was a senior resident was like saying like, I wish he would give me more time to like see patients, and he's like over teaching. And I was like, oh, that was like really great feedback from me, because it spoke to the fact that I wasn't like meeting what the learner wanted per se. So what it started doing was not just with that particular resident, but just in general, is what would be our ideal like teaching relationship today, you know? And so that's something that I'll occasionally say to the resident, and they'll often like pause and be like, huh? And then I'll be like, no, like, do you like how, you know, you tell me when you're feeling pressure to move things and when there's time for us to like explore something a little bit deeper. And I think that that makes it a little bit more comfortable. Then they feel like they can talk to me about, you know, about like the space that they need in order to have the best and more optimal learning environment. And I think finding those little nuances that we can optimize, I think, make a huge difference. Now, as we continue to go down, like some of the other things that were mentioned, you know, what is it about a difficult, like there's learners that are trying and they're not succeeding. And I agree that those are times where, you know, you can pull the person to the side, and, you know, you can appeal to ideals that we all agree in. So, you know, hey, you know, we need to be accountable for the patient for this. We need to make sure that we're meeting these, like, you know, these important pieces are in for, you know, for this patient. And often the person's like, yeah, and as long as you're, you know, not raising your voice and you're talking to the person and it's a dialogue, like what was mentioned, I think that that is a way for that to happen. When it's somebody who is disengaged, then that also is provides a problem. That person who's like, you know, and you know, sometimes our EM residents will come back and be like, hey, this off service person is like not holding up their end of the bargain, and I'm getting stressed out, you know, and you could be having a great shift, but that person's like, you know, not holding the back, right? So in that scenario, then, you know, you can, if you go to the person, you can then at that point try to like figure out like, hey, you know, what do you want? Like, I think like Christy, like, what do you want to get out of this particular rotation? You know, what do you like? You know, like, tell me a little bit about, you know, what you're doing right now, and, you know, what kinds of things can I do to help you kind of take it to the next level. And often, if I can create alignment with that person, and again, share and communicate that I'm rooting for that person to have a really great experience in the emergency department, often I can get that alignment back. And if that doesn't work, then it's easy. Then, you know, then it's about trying to make sure that the person's okay, that there's not bad things happening in their life. And that's not necessarily for me to figure out in that moment, but, you know, for me to talk to that person's supervisor, and, you know, make sure that they know that this person is struggling in the emergency department. Hopefully they're okay, number one. And if they are okay, then, you know, maybe there's some strategies to try to help that person. And I think that early intervention, early escalation is something that I would have called a pitfall earlier in my career that I feel more adept at addressing now than I've ever had before. But I think that's because now I can see that. And honestly, Mike, sometimes seeing a performance drop like that, that's the way we find out that somebody is struggling with personal things at home. And so, you know, you might, you know, people might be like, oh, this person's totally not doing well, and because they don't care, but that's not actually the case. There's stuff happening, there's turmoil happening. And, you know, if we can, as an academic community, help that person, then that level of resilience and support that they'll feel in that moment will actually last for a long time.
Great. Thank you, everybody. So I just want to open it up to the audience. If there's any questions in the last 5 to 10 minutes that we have, feel free either to turn your camera on and ask the question or put the question in the chat. If not, I have a question we can end on, but I'll give it a minute or so.
While people are thinking, Mike, can I share with you all like one of my strategies for that information translation? So,
Sure.
so we talk about how like you teach a pearl. I use this 3-step process to try to help people learn things. One is to teach the pearl. The second is to teach an approach to that pearl. And the third thing is we learn through narratives, we learn through storytelling. If you can share a story, you can like really like hammer that thing home. So, you know, if we're talking cardiovascular, I might share like, here's a cardiovascular pearl, here's a study on, you know, like the commit trial, looking at beta blockers and, you know, and ACS. And, but then, you know, like the approach to it, like how might I put somebody on a pacemaker, or like when I overdrive pace this person. And the story might be the time when I had to help somebody with a prolonged QT who went into torsade. You know, like I have this crazy thing that happened where the person was on Sotalol, and, you know, I was on call and it was like the QT was already 600 and they're like, might go into torsade. And I was like, okay, fine. So Sure enough, I get called, patient's at Dorsad. I come in, 2 grams of mag, and I'm like, that's it. I'm going to drop the mic. I got the answer. And then actually, after I gave it, the patient went back into Dorsad. And so I was like, oh my God, what do I do? Give all the mag that we have in the hospital. And then I gave more, and the patient went back in. And I was like, what do you do? And back in those days, we didn't have smartphones. We just had heavy books, and we would put them in our pockets, and we had really incredible traps. And so I pulled out the book, and the book told me that you can either use isoproterenol or you can overdrive pace. And so I said, I gave isoproterenol, I overdrive pace, and we were able to save this person. And I was humbled, but learned a ton that day. And I hope you remember the Torsad treatment past magnesium with that story.
Thank you. Appreciate it. Also a good story. If there's no questions, I'd like to just close out by just asking, we can start with you, Dr. Blumenberg, what your approach is at the end of the shift to giving feedback to a resident. Just generally, like, what's your way about going about it?
Yeah, so it depends on, of course, on the shift and the resident and what happened. And if we're both just kind of tired, I'll be honest, sometimes I just say, have a beautiful day and see you next time. And sometimes we'll do a little kind of quick powwow, just review some cases, some medical decisions, and some fun. If there was something that we just kind of need to talk about in private, we will go in private to have that discussion. And when possible, don't do it every shift by any means, but I like to send a paper, either a review, some piece of the literature to the residents by email within the next few days. I try to do that occasionally.
Dr. Leck?
Yeah, I like that. And I like to kind of almost do like a walk with like people, like after, like if we're ending at the same time, like just kind of the walk from like the bay to the staff room, the resident room, and to just give, again, like quickly give feedback, but apart from everything else, in the clinical space. And I really like what Adam said about like the follow-up emails. So like I'll also kind of like send people like almost this like a little bit of like a space repetition type thing where you like send them the article that you talked about on shift, or even like I actually didn't really know the answer for this, but I'm gonna look it up for my own learning, and then I'll like send it like as well to like the whole group, again, just as kind of, this is like the answer that we found like on that case. And that again like draws into what Manish said as well about like the power of really like case-based learning, instead of just like something that's really not maybe related to what they have seen on shift. It really like comes alive when they can attach knowledge or like a procedural skill to a very real case that they had, and they can also like follow up in that chart later on down the line.
Thanks, Christy. And Dr. Leck? Dr. Garg, sorry.
Yeah, thanks, Mike. In addition to some of the pearls that I mentioned before earlier about feedback, I would say that for me, if I can ideally give that feedback session to the resident, like with an hour to go, between an hour to 2 hour to go, or half hour, or I hate biting into their own personal time, of the resident. And so like, if I can't get there because it's been so crazy, great, we'll do it at the end. But otherwise, if I can ideally do it then, that's one of the things that I like to do. And I don't like sandwich, like feedback sandwich or something like that. But I do still try to make sure that we do talk about some things that went really well. And then I really do try to give constructive feedback, because I recognize that it's our important duty that when this resident graduates, that they will be able to take care of any patient that comes to the door, and so I kind of look at it like that. And so if we've talked about making mistakes, right, Adam? Like I basically so many of my talks are about all the mistakes I've made, and so I'm always hoping that the trainees learn from my mistakes. And so I guess I would just say that in those kind of moments, if I can talk about what the trainee really needs to do to take it to the next level, then I think that it's open. I think I get a little bit of space and luxury from that in my role that I have, but then at the same time, I think I've seen lots of very, very talented faculty also create all of the constructs from some of the really great pearls like we've heard today, those are the things that I think will help prepare you to be able to have those types of conversations with the learners, and they really can grow from them.
Thank you, everybody. So I just wanted to give another round of thanks to Drs. Blumenberg, Dr. Leck, Dr. Garg, and the SAEM staff for joining me tonight for this talk. And a thank you to all of you who attended this or will be watching it on YouTube later. Appreciate it. And I hope everybody has a good night.